in recent years, we've been very fortunate to have several agents approved for the treatment of patients with serious gram-negative infections. One of those is ceftazine-avibactam. Ceftazine-avibactam is currently FDA approved for the treatment of adults with complicated urinary tract infections. When combined with metronidazole, treatment of adults with complicated intra-abdominal infections. And most recently, it's indicated for the treatment of adults with hospital-acquired pneumonia and ventilator-associated pneumonia. This is an important agent in our armamentarium. A lot of our use right now in our institution is off-labeled, and really what we targeted is for patients with serious infections with KPC-producing Klebsiella pneumonia. So it really has become a go-to agent, for CRE in our institution. In addition, it's also an option for patients with multidrug-resistant Pseudomonas infections, where many of our commonly available or commercially available beta-lactams like meropenem, imipenem, piperacillin, tazobactam, cefepime, where that isolate exerts resistance. So again, and it's that kind of risk versus benefit situation, much like CRE, where we consider using ceftazine-avibactam for a patient with a multidrug-resistant Pseudomonas infection. Another drug that was recently approved is meropenem vaborbactam, or Vabomere. Currently FDA approved for the treatment of adults with complicated urinary tract infections. Again, when we think about this drug, a lot of its use, it's off-label. And in its recently conducted trial, Tango 2, it was looked at relative to best available therapy, which was largely patients who received colistin-based therapy for patients with CRE infections. Overall, looking at across several infection types, in the urine, bloodstream, as well as the lung, what we saw with Vabomere was higher clinical response rates and numerically higher survival rates. So again, we have a situation where we have a drug that suggested, has a better response than colistin-based therapy. And much like avibactam, ceftazine-avibactam, we consider its use largely in patients with CRE infections. In addition to several recently approved agents, we have a number of promising agents in development. One of those antibiotics is ceftriaxone. Ceftriaxone is a siderophore antibiotic and really has a unique mechanism of action, and trials are currently underway for patients with carbapenem-resistant infections. So the way ceftriaxone works is, in addition to functioning like any other beta-lactam, what we find with ceftriaxone, it has a high binding affinity to iron. So when patients have infection, one of our innate immune responses is to create an iron-deficient environment surrounding bacteria. So in these circumstances, what bacteria do is they send out, they open up pumps to increase uptake of iron, which is necessary for survival. And what ceftriaxone does, it binds to iron and is actively transported into bacteria during these acute phases. Very promising drug, and the thing I like most about ceftriaxone is, as we think about antibiotics currently available, they all have their place in therapy, but they all have gaps in coverage. In contrast, with ceftriaxone, it's very active against carbapenem-resistant Pseudomonas aeruginosa, carbapenem-resistant Acinetobacter, Stenotrophomonas, as well as our CREs, both KPC-producing Klebsiella pneumonia, and many of our MBL-producing gram-negative bacteria. So again, it's really a broad-spectrum agent that covers a lot of the major resistant pathogens we worry about most in our clinical, in the clinical arena. To date, it's been studied in patients with complicated urinary tract infections. It was actually found to be superior to imipenem-based therapy. And it's currently underway, and there's a study looking at patients with carbapenem-resistant infections where it's being compared to best available therapy, which is at the discretion of the investigator, and this is I believe is an open label study. In addition to the agents that have recently approved, another agent under development is plazomicin. Plazomicin is a next generation aminoglycoside. It's derived from cisomycin, and the thing that distinguishes it from other commercially available aminoglycosides, it's its ability or its lack of degradation by aminoglycoside modifying enzyme. So one of the major mechanisms of resistance against aminoglycosides is degradation by aminoglycoside modifying enzymes, or AMEs. And what we find with plazomicin, the way it's structured and developed, it really is immune to the activity of most AMEs. So it's really impervious to breakdown by them. To date, it's been studying patients with complicated urinary tract infections, looked very favorable against meropenem-based therapy. And more recently, they conducted the CARE trial. This was a trial looking at plazomicin versus best available therapy, which was again colistin-based therapy. And what we found in this trial, looking at patients with bloodstream infections, there was a mortality benefit with plazomicin-based therapy. Carries all the risk associated with aminoglycosides. Worry about nephrotoxicity with prolonged use. So what we have here is a drug with very good efficacy, same adverse event risk, but very compelling data, particularly patients with CRE bloodstream infections.